Good evening, everyone, and a very warm welcome to today's webinar. Myself, Pritili, and it is my privilege to welcome you all to this insightful session on the topic, the unseen guardian. Today's theme draws attention to a crucial yet often overlooked pillar of modern medicine, the field of anesthesiology, which silently safeguards patients through some of the most critical moments of medical care. We are truly honored to have with us our distinguished speaker, Dr. Tanmoy Dash, an eminent name in the field of anesthesiology and perioperative medicine. Dr. Dash completed his MD in anesthesiology in 1991 from SCB Medical College and Hospital, Cuttack. He began his academic career as a lecturer in cardiac anesthesia at LTM Medical College and Hospital, Mumbai, and went on to serve as associate consultant in cardiac anesthesia at B.M. Birla Heart Research Center, Kolkata. He further contributed as a consultant at Suraksha Hospital, Kolkata. Since 2003, he has been serving as the senior consultant and head of the Department of Anesthesiology, Perioperative Medicine and Pain at Apollo Multispeciality Hospital, Kolkata. His leadership and expertise have significantly advanced patient care in these critical areas. Dr. Dash is also the president of the Indian chapter of International Trauma Care, reflecting his deep commitment to advancing trauma management and emergency care. His areas of specialization include general, regional, transplant, pediatric, and trauma anesthesia. Beyond his professional achievement, he is also passionate about wildlife photography, clinical nutrition, showcasing a well-rounded personality. Today, we look forward to gaining valuable insight from his vast experience and deep knowledge as he shed light on the vital yet often unseen role played by anesthesiologists in healthcare. Now, without any further delay, I invite our esteemed speaker, Dr. Tanmoy Dash, to deliver his lecture. Thank you.
Good evening. Thank you, Pritili, for such a nice introduction. It's been a pleasure to see you here and introducing speakers. Good evening, everybody, and welcome to the discussion on anesthesiology. I hope everyone is able to hear me. If there is any problem with your audio or video, please raise your arm and let us know. Uh, before I start, part of my introduction, which has already been illustrated, I would say that I am, first of all, uh, very passionate doctor and very passionate about my subject, anesthesiology. Now, when I joined anesthesiology, it was very long time back. That time, not many doctors would go into it, but it was always been my first choice, and there is a reason behind it. And that is, the reason is I found anesthesiology to be the most challenging specialty in the entire field of medicine. You will come to know why in this discussion. So everybody has a working definition of anesthesiology. My definition, or rather my statement, is that it is the subject, or it is the science which makes surgery safe, feasible, and possible. Why is it so? Once again, we'll come to know in the discussion. So, without wasting much time, let's get into the topic. I have a PowerPoint presentation to share, which will share right away. I hope you are able to see.
Yes, sir.
Able to see? Okay. Yeah. So, my only conflict of interest, which I will declare during this talk, is that I have taken the help of AI to make some of my slides, but I am very much real. I'm not AI. So whatever part of the talk may be a bit of an information overload, especially to those who are not familiar with anesthesia. But not to worry, I am here to explain. And if you have any doubts, you can always ask the questions which you want to. Okay, so I've named it an unseen guardian because most of the time when patients go through a surgical experience, that is, they get operated, it so happens that they hardly get to meet the anesthesiologist. Um, I'm sure a few of you must have gone through that experience, but so people do not come to know. They meet the surgeon, and sometimes they meet the anesthesiologist, sometimes they do not. Although in the modern day practice, we make sure that anesthesiologists also meet the patient several times before your operation. So that is why, and there are many things which anesthesiologist does which are not which are not known by people. So that is why the unseen guardian. Now, I have already been introduced. Most of the time, either I'm in the operating room or in my office, which is a part of my daily life, which I still work about 12 to 14 hours a day. I spend in the operating room. I spend most of my time over there and in the critical care and other areas. As I said, this is the statement which I go by, that it is the science which makes surgery safe, feasible, and possible. You must have heard that there are major surgeries and there are minor surgeries. But let me tell you today that there is no minor anesthesia. The very first medicine, the very first drug that we pick up to anesthetize the patient can kill the patients if we are not careful. Moreover, this safety is what makes the excellent results possible today. And if you look at the history of anesthesia, it is a very recent science. It is less than 200 years old. It is only back in 1846 that this is the classical ether dome demonstration of where first time anesthesia was given in October 16, 1846. That is why October 16 is celebrated as the World Anesthesia Day. And later on, chloroform came in 1847, and local anesthesia started in 1884. So before that, if you had to go a surgery, either it was not possible, or the technique was a four strong man technique, where you would have to be held down by four people, jabardasti, in a forcible manner, when the surgeon would operate in a very as fast as possible, and that would result in death itself. The pain and the response to the pain can kill the patient. So later on, what happened from the 20th century to present, new agents were developed and safety rules were followed and safer anesthetics were developed. Today, a modern day operating theater looks like this, where you can see the anesthesiologist sitting over there and looking at all kind of monitoring with modern day equipments, which allows the surgeon to operate and concentrate only on the surgery. It's not possible for the surgeon to look after any other thing when he is operating. For that is the specialty of anesthesia is developed in such a way that it makes the surgery, the process very safe by allowing the surgeon to concentrate only on the surgery. Rest, the surgery actually, the entire surgical experience consists of two parts. One is the cutting part. We all know that the surgeon cuts open and then does the operation. The entire other thing is a non-cutting part, that is preparing the patient for surgery and optimizing the patient, and then looking after all the vital organs while the operation is going on, making sure that the patient is not having any pain, patient is not aware of what is going on. So that entire non-cutting part, the anesthesiologist is responsible, which uh, um, is very important to tell you that anesthesia is not just putting the patients to sleep. Many people have the impression that anesthesiologists, they just put the patient to sleep and it is nothing else. But it is much more than that. Putting the patient to sleep is a very very small part. It is just a byproduct of what we do. Uh, Not only do we prepare the patient for operation, we make sure that each and every organ is protected during surgery. We make sure the patient is safe. Airway management comes as a part of. I will tell you more about airway management. Now, critical care is also a part of anesthesia. In fact, the entire subject of critical care was born out of anesthesia. I will tell you more about it later. And so many other things we do, which is much more than patients putting the patients to sleep. In fact, the new coinage for the anesthesiologist is that anesthesiologist is a perioperative physician. Peri means during the entire stay of the surgery patient for the surgery. That is right from before surgery, during surgery, and after surgery. Before surgery, a preoperative assessment is done in the pre-anesthetic clinic, which allows the anesthesiologist to optimize the patient and plan the anesthesia. During surgery, where the anesthesiologist is continuously present, it's not just that we put the patient to sleep and we go back to the rooms. No, we are with the patient all the time, real time, monitoring every heartbeat, every lung, every breath, every heartbeat, and till the operation is over. And once the operation is over, we make sure that the patient is comfortable in the post-operative care, and if required, um, the patient is sent to the intensive care and helps the patient to recover well and without any unpleasant experiences. Okay. Sorry, the slide is not moving. Yeah. Many of you, I think, have the impression that how educated the anesthesiologists are. Actually, the anesthesiologists are equally trained as much as any surgeon or any super specialist surgeon. We have 6 years of MBBS, 3 years of MD or a DNB, and another 3 years of DM or a DRNB in a super specialty like cardiac anesthesia, neuroanesthesia, critical care medicine, pain medicine. All these are super specialties which the anesthesiologists are trained even after training 3 years in MD or DNB. So this is a very highly trained personnel that we have today and who look after your life when you are getting operated. Now, when you get admitted, your entire surgical journey consists of pre-anesthetic checkup, your patient optimization, and final preparation and anesthesia on the day of surgery, your rather your surgery itself, intraoperative care, which consists of monitoring and managing the vitals, emergence and recovery from anesthesia, and pain management. And at every step in your journey, in your surgical journey, your anesthesiologist is there with you. So that is what you should remember. Right from initial assessment to the post-operative care, it is the most vital person to be with you while you go through your surgery. Now, let us start with the pre-anesthetic checkup. This is where safety begins. Every surgical journey starts with a thorough evaluation by your anesthesiologist. Your surgeon must have just diagnosed your condition and I must told you that go and get a pre-anesthetic checkup done. Where a pre-anesthesia checkup actually is the most thorough checkup or the most thorough examination that you will get in your entire surgical stay. Keep that in mind. And that is why a pre-anesthetic checkup takes a little more time than an ordinary checkup, because we start with the cardiac status. That means the condition of your heart, the condition of your lungs. Airway assessment means I will tell you in detail how much. The airway means the respiratory breathing apparatus where we have to capture, because when you are unconscious, we have to find out what current medications you are on, what allergies you are suffering from, and certain blood tests which is important to know before taking the patient for surgery. Now, heart and the lung optimization are the two main pillars, because the heart and the lungs are stressed most during any anesthesia or any surgical procedure. Like the entire surgical experience or the surgery itself, you can compare with a 100-meter sprint. So, for a 100-meter sprint, you need to be really prepared. Now, everybody will not respond in the same way if you run a 100-meter sprint. So, we have to make sure that your lungs and your heart are in optimum condition to go through this particular stress of sprinting 100 meters. So, this to make your surgery safe, we make sure your heart is in optimum condition and your lungs are also in optimum condition. For example, if you are a smoker, we usually ask you to stop smoking, because smoking not only interferes with anesthesia, it also interferes with oxygenation of your lungs. So that is a real um, uh, reason why we ask you to stop smoking. And if you have any bronchospasm, like if you have bronchial asthma, we give bronchodilators, and we also give you breathing exercises, which makes your lungs breathe in their optimum way. So heart and lungs, these are the two pillars. Keep in mind. So every detail matters when we do a pre-anesthetic checkup. Your past surgeries, if you have family history of any anesthesia complications, smoking, as I already said, drug allergies, what current medications you are under, chronic if you have any chronic conditions like diabetes, high blood pressure, asthma, all these things are checked by the anesthesiologist and are fine tuned so that they don't cause any trouble during the surgical procedure. One of the things that we do is an airway assessment, and it is a very vital thing for all anesthesiologists. It's a very simple thing. We make the patient sit in front of us and open the mouth and wide and see how much is visible. This is the full visibility over here. You can see, which gives us an indication that endotracheal intubation or capturing the airway with a tube when we make you unconscious is going to be easy. To class 4, where it is going to be really difficult. So every patient is classified and is known as Malampatti. Malampatti was the name of the scientist or the doctor who gave this classification. We also check your neck mobility and thyromental distance. This is from here to here, and your mouth opening. All these things give us an idea as to how well or how smoothly your anesthesia is going to be conducted. So we form a blueprint, which is your investigation and your heart function and lungs function and kidney function. So this comes in a paper and a printed format. Only when these are ready, we can go ahead. Another classification which we do is known as the ASA. ASA stands for American Society of Anesthesiologists. This is a risk stratification. At the end of a good PA checkup or pre-anesthetic checkup, we either say you are ASA 1, which means you are a healthy patient, no chronic diseases, you are a non-smoker. ASA 2, which means mild systemic disease, right up to ASF 4, which is life threatening, ASF 5, which is a moribund patient. So, accordingly, we kind of tailor our anesthesia according to the ASA risk stratification. Also, the outcome of the patient also depends on the risk stratification. We expect a patient of ASA 1 to sprint 100 meters without problem, whereas we do not expect the same from patients who suffer from life threatening diseases. So, accordingly, risk stratification is done, and we patients are also counseled. So once again, we fine tune your body for surgery. Like diabetes is controlled, anemia is corrected, and medicines are optimized. If your blood pressure is high, we might increase the blood pressure medication. If you if you are on blood thinners, we usually stop the blood thinners like aspirin or clopidogrel, because it might cause excess bleeding during surgery. So according to your unique conditions, your unique type of surgery, we choose what whether three types of anesthesia mainly. General anesthesia, which means the patient is made fully unconscious, where the airway is secured with a tube, and this is used for major surgery. The other one is regional anesthesia, which can be done with a spinal or epidural block. Maybe I'll tell you what it is later. Here, the lower body is numbed and usually used for cesarean sections and for orthopedic surgery in the lower limbs. And in between, there is something known as the blocks, which are very common nowadays. We give nerve blocks maybe in the hand or in the legs, where isolated surgeries in the hand and the legs can be done with the help of a nerve block. Local anesthesia is where you block local skin, a small area which is numbed with the patient fully awake and can be used for minor procedures. Now, you must have heard that do not eat for 2 hours or 6 hours or 8 hours before surgery. This is very important from the anesthesiologist's point of view because when we give anesthesia and you become unconscious, even a small teaspoonful of uh, food from the lungs, food from the stomach going into the lungs can cause severe inflammation of the lungs and patient can die. So we, as anesthesiologists, we make 100% sure that if you have eaten solid food, we make you fast for 6 to 8 hours. And if you have taken clear liquids, can be taken up to 2 hours before surgery. So this is something which is very, very important. Now, if the patient is usually anxious, we do a lot of counseling, try to meet them even before the night of the surgery and in the morning of the surgery. We comfort them, give counseling, but it may not be enough. So we sometimes use anxiety relieving drugs to relieve the anxiety. We use antacids to prevent aspiration or neutralizes the stomach acid, and other drugs like analgesics and antiemetics. Antiemetics means drugs to prevent vomiting after surgery. Here is a very nice comparison picture between a cockpit of a plane and anesthesiologist machine. You can see that both are similar. In fact, a lot of studies, and if you're interested, I can give you the links later on, have been done comparing these two professions, the pilot and the anesthesiologist, which are very similar. These are two of the most stressful professions of the world also, because directly the lives of people are in our hands. For a jet pilot, life of many people is in their hands. For the anesthesiologist, one at a time, but nevertheless not any less. uh, every mm, minute, every second is monitored, and we function with the same precision, same vigilance. Every monitored is everything we monitor, and everything, not for a single second our eyes are off the patient's parameters. And just like a flight has a takeoff, uh, cruising and then landing, and which are equally important phases. And so, similarly, in the anesthesia process or the surgery process, in anesthesia, we take you under, it is known as the induction part. Maintenance is where we maintain your anesthesia so that you are unconscious and do not feel the pain. And emergence is what, is like the landing. We bring you out of anesthesia very safe and very conscious right in the table itself. So these are very, very comparable studies. So an induction, as I said, it is a kind of orchestrated symphony. Every drug, every second is calculated for your safety. Every drug is measured as per your condition and as per your body weight. Whether you are 100 kgs or 20 kgs, it doesn't matter. So it is the induction process takes place by starting with pre-oxygenation, so that it builds up oxygen in the body, and so that if there is for some reason in this laryngoscopy and intubation is delayed, then this oxygen buildup will help. We make the patient unconscious by giving an induction agent, which is propofol. You might have heard of. Propofol is a IV induction agent. It takes only 15 to 20 seconds for the patient to become unconscious, which the time which the drug takes to reach from the arm to the brain is all that is needed to make the patient unconscious. Muscle relaxant is given after that, so that not only muscle relaxant not only helps to capture the airway and put in the endotracheal tube, but the most important reason is why the muscle relaxants were developed is that so that the surgeon can get inside the body, get inside the abdomen or the chest easily where the muscles are relaxed. If the patient is unconscious and surgeon is not able to get inside because the muscles are rigid, he will not be able to operate. So it is made possible by giving muscle relaxants. Once again, as I said, muscle relaxants were one of the last things to be discovered, and has been possible to do major and supra major surgery only after muscle relaxants were invented. Intubation is done, laryngoscopy, endotracheal tube is secure so that airway is secure and gastric contents will not leak, and this also maintains oxygenation. And we confirm it by doing measuring the carbon dioxide which comes out of the endotracheal tube. Uh, okay, so this is airway management. I told you all about it. I'm not going into the details of difficult airway, but basically, airway is captured by endotracheal tube by using a laryngoscope. And the other methods of airway is an emergency airway, which is done by, suppose you are not able to intubate, you can directly cut over here in the front of neck axis, it is called FONA, and put in a small tube by using a scalpel and just put in a small tube. This is a front of neck access or surgical airway. This is done in an emergency where you cannot intubate or cannot ventilate. This is the anesthesia machine, which is a marvel of modern technology. This delivers anesthesia gases, monitors every breath, and then keeps you alive during the entire process of surgery. This contains of monitors, vaporizers, contains of a ventilator, a breathing circuit, and a carbon dioxide absorber, which absorbs the carbon dioxide from your expired breath. It contains oxygen and gases like nitrous oxide over here. So this is where this is the workstation of every anesthesiologist who is doing, and this is a remarkably safety device right from beginning to end. This is a series of safety devices which are incorporated in this machine and which keeps your life safe. So when the anesthesiologist is with you during the operation, he is kind of having eyes on every organ and simultaneously monitoring all the vitals. He watches your lungs, heart, brains, kidneys, and more all at once. This is heart, this is oxygenation. Capnography is the lungs, part of the lungs, which we see the carbon dioxide. We see the blood pressure, the urine output, the basis, depth of anesthesia. I'll tell you a little more. It is monitoring the brain, the temperature monitoring, which is very, very important, and capnography once again has been depicted in this slide. So all the things, so many things, the anesthesiologist is looking after. So we start with ECG, and this is the normal ECG. And moment there is something change, there is ST depression, means there is some amount of ischemia or heart, the vessels in the heart is not getting blood, or there is some arrhythmia or abnormal rhythm, or there is a pacemaker function which is abnormal. Immediately we come to know and we take measures to correct it. Another important thing is the hemodynamics. Hemodynamics means maintaining blood pressure, which ensures every organ receives oxygen rich blood. So that is usually measured by a cuff. Sometimes in a major, we directly put a line in the artery so that it can see a direct arterial pressure tracing. Sometimes we also measure the cardiac output directly from the heart by putting in a catheter, and so do CVP monitoring and cardiac output. These are invasive monitoring. You do only cuff, it is non-invasive. So, but depending on the requirement, we do invasive or non-invasive monitoring, and which helps us to maintain the hemodynamics, which means once again, we make sure that oxygen rich blood reaches every vital organ in the body, the brain, the heart, the kidneys, and every organ in the body receives blood in a proper pressure. And if the pressure is low or high, then we control it by giving a combination of drugs and anesthetic agents. So once again, uh, basically the anesthesiologist, with the help of the machine, breathes for the patient. So this delivers life-sustaining oxygen to the body. The same thing. So I will just skip over this slide. As I said, you protect the brain. Intraoperative awareness can occur in 1 to 2 per thousand cases of GEA, general anesthesia, and which is can a terrible thing to happen. You must have heard of it, or you must have seen a movie or something on it. So if the patient wakes up under anesthesia, it can be a terrible experience and can lead to post-traumatic stress disorders. So this can be prevented by a monitoring known as BIS. BIS is bispectral index, short for that. Basically, we uh, look at brain waves and make sure that the BIS is in an acceptable value, which is 40 to 60, so that we know that the patient is unconscious enough not to be aware of what is going on. So this is BIS monitoring, which is a part of all major surgeries nowadays. Temperature management is very, very important. You must, I don't know whether you are aware that our body temperature is regulated very tightly by the body. Even 1 or 2 degree here and there can cause serious complications. So usually under anesthesia, the temperature tends to fall. Because it tends to fall, we have to be very, very careful and make sure that the patient is actively warmed. So why is hypothermia, fall of temperature is known as hypothermia. So why is hypothermia so very important? Because hypothermia can impair the blood coagulation. It can make the patient at increased risk for infection. It can cause arrhythmias in the heart. It can delay drug metabolism. So how do we combat it? We use warm blankets, forced air warm blankets. We use warm IV fluids, and we make sure that the operating room temperature is under our control. So temperature management forms a very important part of anesthesia management. Fluid therapy is once again very important and incorporated in anesthesia. Uh, when operation is going on, there will be loss and blood loss. There will be loss by urine output, and there will be loss by evaporation and breathing of the patient. So all these things are very monitored and measured all the time by anesthesiologists, and we compensated by giving crystalloids, blood, or colloids as and when necessary. Crystalloids are saline like substances. Colloids are very thick fluids, and blood products. I'll tell you a little more. So if the blood loss is more, we give blood. This is Paxil. We give blood products, which are fresh frozen plasma, platelets, and cryoprecipitate. Now, whole blood is not given nowadays because of logistical reasons, but then we keep a measure of how much blood loss is going on during the operation all the time. We measure the swabs, how much blood is lost, how much the hemoglobin is, and accordingly we give the blood and blood products. Once the operation is over, muscle relaxants are reversed. Not only we have drugs which reverse the muscle relaxants immediately. One thing you must have realized by now that the medicines or the drugs that we use in anesthesia are the most powerful of any medicines that you can ever come across. Even the even the chemotherapy drugs used in cancer come a very distant second. Here we are talking of drugs which can make you unconscious in 15 seconds and can wake you up in another 15 seconds or so. Nowadays, the reversal drugs are so powerful that you can wake up right on the operating room and you can start breathing. Your airway reflexes come back. You open your eyes, and tube can be taken out, and you can wake up right in the operating room. But still, we shift uh, the patient to the recovery room, which is known as the PSCU, post anesthesia care unit, where the vigilance continues. In fact, the continuum, this is known as continuum of care, where the you are monitored till you are fully awake, stable, and pain free, and you are ready to go from the ICU. So here, the care given or the monitoring and the vigilance remains the same as the operating room, and we make sure you are comfortable, pain free, blood pressure is normal, temperature is normal, you're not having nausea, vomiting, and when you are ready to go, usually our PACU time in our hospital is around half an hour, and we make sure you're comfortable. And only when the anesthesiologist is satisfied, we go by a scoring system known as Aldrich score. I'll not give you the details, just the name is enough. So anesthesiologist signs off. He's the one who gives the permission for the patient to be shifted out of the recovery room. That means he is making sure that you are safe. Pain is a very important part of management. But one of the most important things which the patient remembers is the pain. So, pain is the concept of pain control is multimodal. That means not one drug, not one way, but in many ways, which is a combination of like paracetamol, diclofenac, opioids like morphine or morphine. We try and give less and less morphine because this can cause respiratory depression. We try to make it multimodal so that each of these drugs are used in a smaller dose, and the effect is, it targets multiple pain pathways. So pain relief is very very important. Regional anesthesia, as I told you, other than general anesthesia, is also consists of epidural, spinal blocks, and nerve blocks to provide superior pain control and fewer side effects. So, if the patient is having, for example, patient is having a fracture of right arm and has a very bad lungs, and giving a general anesthesia to such a patient would put the patient's life at risk. So, just a nerve block and the operation can be done on the arm, and patient does not have to be given general anesthesia. This is one of the advantages of a nerve block. Preventing post-operative complication is an important part of anesthesiology. So we do proactive management. We give drugs to prevent nausea and vomiting, to prevent deep vein thrombosis, which can occur due to immobility. We make sure that the patient is warm, as I told you about the temperature. We make sure the patient is warm and patient does not have shivering in the post-operative period. So these are the preventive measures we tell you. Um, Trauma is a very important um, condition where anesthesiologists play a very big role. You must have heard of the golden hour. The basic skills which anesthesiologists learn in the operating room come very useful not only in intensive care but also in trauma, where this rapid airway access, rapid access to IV lines, all these things has to be done in, within an hour, and within minutes after the patient reaches. So this is where an anesthesiologist skill become very very important. One of the things which anesthesiologists have taught the rest of those intensive care people is rapid sequence intubation. That means capturing the airway within 60 seconds, and this is done so that the patients can be saved, and at the same time uh, prevent aspiration from stomach contents. So everything that we do in endotracheal intubation, we do here, but we do it within 60 seconds, which helps the patient to, um, you know, get the patient quickly ready, whether it is for surgery or it is for resuscitation. If there is massive hemorrhage in trauma, patients have lost liters of blood. We make sure that um, it is kind of monitored. We determine how much the coagulopathy that is occurred. Coagulopathy means abnormal coagulation due to loss of blood. What is essential blood to be given, and drugs which can help the patient to survive by reducing the bleeding. So all these things, there is something known as cell salvage also. When the bleeding is massive, the blood can be taken directly and purified through a filter and then given back to the same patient. Something known as massive transfusion protocol, which is activated in any hospital, and they have a protocol, and blood products are given is 1:1:1 ratio. There's Paxil, fresh frozen plasma, and platelets, and this prevents what is known as the dark three angels of death, which is hypothermia, which is temperature lowered, acidosis, which is increase of hydrogen ions in the body, and coagulopathy, abnormal coagulation. So these three, when it develops in a trauma patient, can kill the patient, and that can be saved by giving blood and blood products, keeping the patients warm, and giving massive transfusion to make up for the blood loss. The intensive care is said to be the anesthesiologist's second home. Um, Many or rather most intensive care specialists are trained in anesthesia. Many anesthesiologists work in intensive care as a full-time profession. So here there are so many things to do where critical care medicine is a separate subject now, but once upon a time it was born out of anesthesia only. Consists of all these things: ventilator management, sedation, hemodynamic support, nutrition, and multi-organ support. Now, mechanical ventilation is a very important part of managing critical care patient, and the basic skill, mind you, comes from anesthesiologists. So when the lungs fail, the anesthesiologist turned intensivist takes over the breathing with precision and engineering. These are drugs, vasopressors and anotrapes, which keep the circulation going, and this can be given via pumps, and also different types of drugs are used for different indications. Dobutamine for weak hearts, noradrenaline for keep the artery or this contracted so that pressure is maintained, and adrenaline when the patient has had a cardiac arrest, we use adrenaline. Vasopressin is a second line drug in septic shock where the vessels are dilated and the vessels are constricted with the help of this drug. Sepsis is very common in critical care, which can happen. Sepsis can lead to multi-organ failure. So this is fighting the invisible enemy. So here also the skills which come in use are are learned in anesthesia as a basic science. So once again, anesthesiologists contribute to the intensive care of sepsis patients. COVID-19 proved that anesthesiologists are frontline warriors for COVID. I'm sure you remember the horrible time which all of us went through during COVID, and anesthesiologists, including myself, we were in the front line of intensive care and operating room. Anesthesiologists are the first to respond in any such health crisis, and the essential skill. COVID was very much a lung disease, lung problem, and every time anesthesiologists help to save the life of patients by doing critical care, by contributing to the critical care. In fact, Time magazine put an anesthesiologist in the front cover in April 2020 during the COVID, and they were called the heroes of the front lines during the pandemic. Chronic pain is another problem which anesthesiologists contribute. It is a subject in itself. Many anesthesiologists they specialize only in chronic pain. It is a fact that 1 in 5 adults suffer from chronic pain, and it costs a lot in productivity. So anesthesiologists, with their skills, not only do a comprehensive pain assessment, but they chalk out treatment plans, do interventional procedures, and help to relieve chronic pain. So these are the a few of the chronic pain measures which the anesthesiologists do. Injections and nerve ablations in various part of the body, in various nerve roots. So that takes care of the pain. There are many recent developments to that. I will not go into the details, but these are revolutions in chronic pain management, with devices which can be implanted and which can help, to conquer chronic pain. And you can keep on consulting your pain anesthesiologist who does it. Opioids, which are morphine like drugs, cause addiction and is a big problem all over the world. Anesthesiologists, by developing multimodal anesthesia, regional nerve blocks, interventional procedures, all of this combine to help to reduce the opioid crisis. This is an important aspect which is worth remembering. Future is looks very bright. Anesthesiology is the cutting edge of high tech medicine, as you all must have seen by now. The future is even more. Uh, Robots have come in a big way. AI has come in a big way, but this is not going to replace the anesthesiologist. Not for now. But AI is certainly helping our practice, and that is what is important to remember. And we do a lot of things we are looking forward in the future, and in the future, anesthesiology promises to be more safe, more varied, and all the more helping the patients. So World Anesthesia Day, as I told you, is celebrated in 16th of October. This came out by WHO last year. I would like you to go through this. That when chaos strikes, anesthesiologists actually being calm. When seconds decide survival, They bring skill, science, and soul. In every disaster, epidemic, or emergency, it is the silent precision of the anesthesiologist that turns fear into hope. From field hospitals to operating theaters, from intensive care units to rural clinics, they stand as unseen guardians of breath, pain, and life itself. So, on this World Anesthesia Day, um, they have saluted every anesthesiologist who rises to the call. It's just anesthesiology is just not a specialty; it is the pulse of every emergency, the bridge between chaos and recovery. So that is what I would like you to remember. And um, so next time when you enter a hospital, do remember that the doctor who watches over your life before, during, and after your and wherever you are needed. Thank you. I hope you stop sharing.